I guess we'll get started. Thank you, everyone, for coming to join us for today's AAPOS Adult Strabismus Committee webinar. We're very excited to discuss today's cases on the topic of complexities of vertical strabismus in adults. We have an amazing panel of strabismus experts, including Dr. Hilda Capot from University of Miami, Bascom-Palmer, Manasa Indaram from the University of California, San Francisco, Carlos Solarte from the University of Alberta, Cami Gunton from Wills Eye Hospital, Linda Doggy from Mass Eye and Ear and Boston Children's, and Federico Velez from UCLA. So the way this is going to work is each panelist will present their cases for about 3 to 4 minutes, and then we'll have a discussant who does not know the diagnosis or treatment that was performed, who will analyze the case and discuss surgical options. Then the panelist is going to finish off the case and discuss the diagnosis. And then if we have time after the case, other panelists can comment about the case itself too. This webinar is being recorded and will be posted for future viewing. So without further ado, let's get started with Dr. Capot.
Hello, everyone. Let me just go ahead and share my screen so we can get started. Okay, so I'm going to go ahead and start with the first case. Again, it's an honor to be here participating in this webinar. We're going to start with a pretty simple case just to get you all warm up. So I have no financial interests or relationships to disclose. Let's start with this man. He's a 67-year-old man complaining of binocular diplopia for almost 2 years. The double vision is constant at distance, intermediate and near, and is horizontal and vertical. Past medical history is significant for radioactive ablation 14 years prior. He now has hypothyroidism and is on Synthroid. He was diagnosed with thyroid eye disease 2 years ago after the onset of diplopia. And when I first saw him, he was on that PESA trial. Visual acuity is 20/20 in both eyes. Refraction is low hyperopia. Intraocular pressure and color plates are normal, as well as pupils. He has minimal proptosis with hair tail of 21 in the right eye and 20 in the left eye. Slit exam and fundus exam are essentially unremarkable. So his ocular motility reveals anisotropia of 25% diopters at distance with a left hypotropia of 12% diopters. And near the isodeviation is smaller and it is intermittent, measuring 14% diopters, and the left hypotropia is intermittent with 4% diopters. He has some degree of stereopsis. So this is the video of the patient. You're going to notice that he has some limitations to supraduction of the left eye, and that's why he has a left hypotropia. And he also has some limitation to abduction of the left eye, explaining the isotropia. I'll let you see the video. Okay, so I'm gonna go ahead and let my discussant tell us a little bit about what might be going on, additional testing and surgical plan. And to make things easier, I'm gonna show you the motility in different positions of gaze with the measurements.
Thank you, Dr. Capo. This is a really interesting case and perhaps quite, I wouldn't say uncommon in the world of adult strabismus. The thyroid eye disease is in our practices is coming quite often. This case exhibits a couple of interesting features. The motor test and the incompetence definitely suggest a tight left superior oblique, specifically in the picture looking to the right, and we can see how the superior oblique it looks very tight. In our practice, we definitely like to have imaging in these cases. We like the coronal views. We like to analyze the muscles very clear, specifically if that superior oblique is tight, or if that superior oblique is enlarged, or not only those ones, but only on the inferior ones, in the inferior rectus, because the limitation in elevation is quite limited as well. In our practice, and perhaps in my experience, one will be looking into weakening the left superior oblique. That will be great for the concomitants, but the risk of reversal and down gains can be quite significant. And that will be something that I'll be a little bit scared of. Because actually, if this person gets a reversal and this gets the eye starts to go higher rather than lower, this can be a significant double vision in down gaze. Now, something that you didn't mention, but also will be interesting to see is the torsion, is to see if there is incyclo or excyclo torsion in this case, and double Maddox Ross will be also important for us to understand. As a surgical planning, maybe I prefer if the forduction test really doesn't say otherwise of as a Brown's-like limitation. I will be considering a right superior rectus weakening on the opposite eye, try to balance. I definitely will prefer to have, if I'm going to have a double vision, try to have it in up gaze, not in down gaze. So the person will be able to read and to do the normal day-to-day. But definitely, these are only ideas, and definitely the CT scan definitely will give us a little bit more information. Something interesting as well is the discrepancy between the distance and near, because at the distance, definitely there is more ET than near. And I don't know if this could have overlapping a sagging eye syndrome in this as it is in this age group, but that will be something to consider on the CT scan as well. For the horizontal, if the medial rectors are very tight, there is no sagging eye syndrome, I definitely will go with a bimedial rectus recession. But if the CT scan confirms that there is actually on top of the thyroid sagging eye syndrome, I may consider as well some combination of the reposition of the lateral rectus with medial rectus recession. Those are my ideas about this case.
Great. Well, those are great comments, and I think you hit it right on the nail. So I'm going to show you. So the patient did have, as you mentioned, limitation to supraduction in adduction, and he has some overreaction of the superior oblique on the left side. And he did have the 8 degrees of incyclo torsion. So when we see a patient like this is a red flag, and it's something that we need to immediately think about involvement of the superior oblique or superior rectus. So we did imaging of the orbits, and you can see here enlargement of the medial rectus muscle on the left side, and also enlargement of the superior oblique on the left side as compared to the right side. So our impression, final diagnosis, it was thyroid eye disease with esotropia and a Brown's-like syndrome in the left eye. So superior oblique involvement is not very common in thyroid. It has been reported. This is a report from the group from UCLA. In their cases, they all had enlargement of superior oblique muscles and imaging. The forced suctions were positive with restriction to elevation in adduction. All patients had an A pattern with incyclo torsion, and every had improvement, significant improvement with weakening procedures on the superior oblique muscle. This is a paper with Monte Del Monte. He had 7 patients with pre-op torsion and 15 patients that developed intorsion after surgery. They had excyclotorsion before, developing cyclotorsion after. And when they analyzed imaging studies, they found that only an increase in the thickness of the superior rectus and superior oblique muscle were significantly associated with pre-op and post-op torsion. So they suggest patients with a small amount of preoperative excyclotorsion, that is less than 3.5 degrees, in the presence of tight inferior rectus muscle should be carefully evaluated for possible superior rectus and superior oblique involvement. And this was also emphasized by Jonathan Holmes. If we miss this diagnosis, the surgery may result in a symptomatic torsion and A pattern exotropia, if we don't address the superior oblique overreaction at the time of the surgery. So again, minimal excyclotorsion or encyclotorsion in a patient should indicate a tight inferior, in the presence of inferior rectus muscle that is tight, should indicate a tight superior rectus or a tight superior oblique muscle. So assessment of torsion and forced suctions will be helpful to identify these patients. So how can we weaken the superior oblique? We can either do superior oblique tenotomy or superior oblique lengthening. This is a lengthening with the expander as described by Ken Wright. We're all familiar with it. We can also do lengthening, which I like, with a splitting of the tendon, because that way we avoid having hardware in the eye. And this was my plan. However, when I went in, this is the way I perform it. I get the tendon, split it with a small tenotomy hook, place my sutures, cut the tendon, and then suture the ends together. So this gives about a 10 millimeter lengthening of the tendon. However, in this patient, the superior oblique was so tight that it was impossible to really bring the tendon forward. I ended up doing an expander of 6 millimeters and recessed both medial rectus muscles suggested. Fortunately, he was pretty much ortho in all positions of gaze. He did not develop any diplopia and down gaze, and he had complete resolution of the Brown's-like syndrome. You can see here how well he can elevate that affected left eye, and he has pretty good range of motion. So take-home points: if you see a patient with a hypertropia accompanied by insect torsion, you should suspect an ipsilateral type ipsilateral superior oblique or contralateral superior rectus muscle. Manifestations of a tight superior oblique in the setting of Graves' disease includes an A pattern strabismus, insect torsion, and of course restrictive limitation to elevation in adduction. So use imaging studies to identify affected muscles and assess torsion and force duction to determine which muscles to operate on. Thank you for your attention.
Thank you so much. That was a great case. We're going to move right along to Dr. Ndaram's case next.
All right, thank you all for having me, and thank you all for joining in tonight. I'll be discussing another complicated case of vertical strabismus here. I have no relevant conflict of interest or financial disclosures related to this talk. So our patient here is a 62-year-old male with a history of a horizontal and vertical diplopia following a stroke 5 years ago. He presented to us needing to keep his chin up quite a bit in order to see single. He was quite interested in strabismus surgery before he underwent ptosis repair to correct his diplopia. But his one caveat is that he only wanted surgery in one eye, on his left eye. He has a pretty extensive past medical history. He's not a very healthy gentleman, a history of neurofibromatosis, end-stage renal disease, hypertension, atrial flutter, and congestive heart failure. So going to his exam, his visual acuity was quite good. He did have some stereopsis, but with his anomalous head posture when he's in down gaze. You'll note that his pupillary exam revealed a poorly reactive and dilated left pupil. And then for his sensory motor exam, he has a significant upgaze limitation in his left eye with some downgaze limitation, but less so. His adduction and abduction are normal. And then his deviation in primary was a left exotropia of 20 prism diopters that increased on upgaze and decreased on downgaze. And then in addition, he had a left hypotropia that likewise increased on upgaze and decreased on downgaze. And then here you can see his presentation to us with his marked chin-up posturing in order to maintain his single vision. And then with his eyelid lifted, you can see in his cardinal directions of gaze, his motility, as well as his motility and his alignment. So I will now ask my discussant, Dr. Daghi, what do you think is going on and what would you do next?
So it looks from the motility exam, if you could go back just to the sensory motor slide. Nope, the one before that has the numbers on it. It looks like he has a partial third nerve palsy, an incomplete third nerve palsy. The muscles most affected are the superior rectus and inferior oblique. The inferior rectus less so. He clearly has preserved superior oblique function, and the medial rectus is not as poor. The pupil is large. He does have a nice area of fusion with chin-up posture. Oftentimes, I mean, it's a sign of a partial third, not a complete third. He does have some preserved down gaze. What would be interesting, and he does have stereo, it would be interesting to wonder whether one of the reasons he has fusion is that he has some preserved inferior rectus function with excyclotorsion balancing the incyclotorsion of the superior oblique, allowing him to fuse with that chin up posture, because not everyone with a partial can fuse. So this is a nice case because you have a patient who can fuse, and what you really want to do is to address his ocular torticollis. See if you can get him a nicer area of fusion, closer to primary position, or maybe with a subtle chin-up posture, which will enable him to read or walk down a flight of stairs. The chin-up posture he exhibits, which you can show us in the next slide, which you have for us, is really pretty severe when it's not a functional. It's not a functional posture, so it would be easier for him to sort of close the left eye or wear a patch than to walk around like that. To me, the first question from a strabismus standpoint is, how tight is the inferior rectus? You've got to do something. I'm imagining if he had this as a cerebrovascular accident several years ago, he's developed some inferior rectus contracture, in spite of the fact that it's part of the third nerve because the superior rectus is in poor form. And on top of that, we have a strong superior oblique. So chances are forced abductions are going to show a tight inferior rectus, and you might need to relax that. You do have a wonderful situation where he has a relatively intermittent small angle exotropia. So then the question is what to do about that exotropia. You could be a little creative. You could, oh, and on top of it, the guy's a vasculopath. So you don't want to operate on 3 rectus muscles. So the thought of doing a lateral, a medial, and inferior does not seem very pleasing. So your options include an inferior rectus plus a Nishida-like procedure where you elevate the medial and the lateral, or you might want to be a little creative, since if you look at his sensory motor exam, he's got a much bigger hypotropia. If you go to the numbers slide, the slide that has this, yeah, exactly. So if you look in gaze right, his left hypo is 18, and gaze left, it's really nominal. It's only 6. If you relax the inferior rectus, that'll be fairly gone. You could consider the possibility of an inferior rectus recession along with a medial rectus resection and possible elevation to get rid of some of that incompetence. So that's key. I suppose if the inferior rectus is not tight and you want to preserve some of that down gaze, because if you look at a sensory motor exam, it looks less bad than his chin up posture, you could consider some sort of recess resect that's asymmetric with more elevation of the medial rectus on the right, but I would doubt that his inferior is loose. I suppose you could consider doing something to his superior oblique, but I don't know. He's got some nice fusion in down gaze. I'm not sure I would take that step.
Well, thank you so much. I think all of the points that you had made are all ones that I had thought about quite a bit. His case was obviously quite complex, and you're absolutely right that the underlying diagnosis was a partial third nerve palsy, secondary to his CVA. Intraoperatively, his forced abductions, I was expecting the inferior rectus to be tight, but it was not, and so it led me to move towards a transposition type surgery, and then trying to be creative with that with a unilateral surgery was really where the struggle came from, because as you mentioned, I didn't want to operate on more than 3 muscles, and I wanted to make sure I'm addressing everything without inducing any secondary deviations or worsened diplopia. But so essentially what I had done was a augmented NAP resection. I transposed both the lateral and the medial rectus towards the superior rectus along the spiral of Talot. And to address the exotropia, I resected the medial rectus in doing so. And this is based off of a paper that was reported multiple times, but there was one series in JPOS in 2016, which showed good outcomes with this and correction of both the exotropia and the vertical deviation, and they reported no torsion. At his postoperative adjustment, he had quite a bit of overcorrection. As you can see, he went from a left hypo of around 20 to 25 now to a left hyper with an exotropia. So I recessed the left lateral rectus a few millimeters. I put both of those on adjustable sutures and was able to achieve a relatively tolerable outcome for him, and expecting that perhaps there would be some postoperative improvement with a little bit more time. But given the, the underlying sort of title of our webinar here, and that it's complexities, I'm going to show the complexity that sort of came from this particular case to go further. So at postoperative month 2, he continued to demonstrate this persistent left hypertropia that was quite marked. His horizontal deviation improved. I think that these motility restriction of both the adduction and abduction reported here is actually erroneous. I think it was more just secondary to his discomfort. It was relatively normal, but he maintained the same motility in his left eye, but he now has this larger left hypertropia or persistent left hypertropia. But the thing that was most bothersome to him was this 15 degrees of left encyclotorsion, which was surprising, but also unexpected at the same time. And so at this time, I was sort of left with a situation about, what I should necessarily be doing next. And so essentially what I had done was I took down any of the posterior augmentation sutures that I had placed for the transposition, and then I recessed the left medial rectus and reversed it along the spiral of Toulouse. And I actually convinced him to allow me to do surgery on his right eye, and did a right lateral rectus recession, and ended up having to put the superior rectus on an adjustable suture as well. So it ended up being a much more complex surgery than I'd originally intended from looking at from the measurements. But I think that goes along sort of the theme of this webinar, in that vertical muscle surgery doesn't necessarily go along the plans that you make, unlike many times horizontal muscle surgery does. But with this, he ended up doing quite well. Postoperatively, I saw him actually 2 years postoperatively, and he continues to do quite well with excellent alignment, improved vertical motility, as well as now fusion now in primary gaze. Although he certainly does have vertical concomitants, and he had his ptosis surgery and ended up looking quite good as well. But just to sort of go through some learning points and take-home points for me from this case, which is now several years old for me, and I've certainly changed the way I approach these cases, is that I've understood the power of a transposition surgery, especially vertical transposition surgery, in that you can get quite a bit more than the papers have described with the amount of vertical deviation that can be corrected. Many of our papers say that you could correct about up to 30 prism diopters of hypotropia with a standard nap transposition, and with augmentation sutures even further. But I've actually found that to be even more than that. And I have seen some cases of overcorrection such as this. And then I've grown out of favor of the resection plus transposition with the nap transposition, essentially because of the potential for iatrogenic torsion, which to me, even though it wasn't reported in Lee's paper in 2016, I do think has a possibility or as a realistic possibility of actually happening more often than was actually reported. And then one other thing that I would potentially consider, which I hadn't in that moment of when I saw this patient, was considering doing a partial transposition, kind of what you had alluded to, Dr. Daghi, about doing a sort of a Nishida or a partial transposition of the horizontal muscles in order to preserve the vascular supply. But in doing a partial transposition, as shown in this picture here of the medial and lateral rectus muscles, similar to the nap transposition to the superior rectus, but then also allowing you to recess and resect those same muscles in the inferior halves, would allow for both the correction of the hypotropia as well as the horizontal deviation, and likely to result in less risk of torsion.
Well, that was a great case. And the end results were fantastic. And those are some very interesting procedures for the partials. Very cool. So we're going to move on to Dr. Solarte next. And he'll give his case next.
Thank you, Jason. So I want to present this case. This case came to our adult strabismus clinic. As you say, I have no actual potential financial interest or conflict about this presentation. This is a gentleman, 65-year-old male, who has been very healthy all his life. He enjoys sports, but he has been noticing 4 months of diplopia, mostly vertical. He was diagnosed about a year ago with a thyroid disease. And this has been building up according to him, but his endocrinologist confirmed that he was doing quite well at the time. But he has developing also significant head posture, very difficult to drive, very difficult to work, although he's in the almost retirement. He's a very healthy, otherwise person from the eye perspective, 20/20 in both eyes, and the anterior and posterior segment is completely unremarkable. When we examined him, we found a significant right hypotropia, 20 to 25 present diopters, which improves slightly when he looks down, increases when he looks down, and he has a chin up, face right, tail right for his posture. And we evaluated him in our unit, and we decided, okay, we might need to consider strabismus surgery, and let's go for inferior rectus recession in the right eye, and the hypo, and doing a complementary with a recession of 4 millimeters in the left eye. It's quite a small recession. On the force reduction test during the surgery, we found that the eyes were significantly restricted in the area of the inferior and superior rectus, and the eye, and all these muscles were incredibly tight. And initially, we have a grade. He was happy. He was a now right hyper of 8. When he had his head posture, he could be orthotropic, and actually doing quite well. He was again driving. He was very happy. He came back about 3 months after surgery, but now it's in a reversal. Now we have a right hyper of about 18. We can see the downdrift now with superior oblique starting to overact. And it's difficult for him because now everything has shifted and everything is in a reversal, and he's struggling now to drive and to have his day-to-day life. So our questions here is, based in this situation, what are the main issues that we need to consider in this case, and what will be the best way to approach the case, and specifically the overcorrection?
So I'm Cami Gunton, and I was going to discuss this case. It's a very interesting case. I think the first question is the if you go back to the beginning slides that show the initial motility before the surgery was done, is this really thyroid disease? There's a tight inferior rectus, but the pattern is a little bit unusual for thyroid disease, with the hypertropia being greater in down gaze than it is in up gaze. And the deviation is worse in gaze away from the tight inferior rectus. So you could say, well, that's the tight superior rectus that you're seeing in the right eye. But I'm just wondering if was there imaging that was done at that point? Because it might be helpful to look to see, is this thyroid disease? It doesn't sound like the patient really had the exophthalmos or other signs that were associated with thyroid disease. So that's one question that I had is what was causing those muscles to be tight, and were there other muscles that were potentially tight even before the first surgery? And then in regards to what the question that you asked about, which is what to do following the recovery from the first surgery. Absolutely, there's a reversal of the pattern. This is more consistent with so not this slide, I'm sorry, but if you go to post the surgery, it's more consistent with what you would see if now you had unmasked that the right inferior rectus was also tight. So you see I'm sorry. Oh, yeah. So I'm sorry that you had unmasked that the opposite inferior rectus was also tight. The interesting things that you see in the motility that you see here is that there's downdrift of the left eye and lack of proper elevation of the left eye as well. So could this be a superior oblique that is tight that's there as well? One of the questions that I also thought, again, imaging at this point would be helpful to see which muscles are enlarged and what's going on in regards to the thickness of the muscles. I think that doing the if you were doing the surgery, you'd want to do forced suctions to see, is the inferior rectus tight? Did you unmask an inferior rectus on the other side? And then in terms of how to correct this, I think it depends on what's happening with your forced suctions. You either need to do something for your superior oblique in the left side or the inferior rectus on the other. I think it depends on what you see in the forced suctions.
Yeah, Kimmy, thank you so much. Yes, absolutely. And when we look into this, 3 months after surgery, and what happens, the series of events here are quite interesting. Because actually we decided after discussing in our group and everything, and specifically with the patient didn't want anything done at this point with the left eye. So he said, specifically, let's stay for now with the right eye, please. I don't want to touch my left eye. So we consider, okay, why don't we explore the inferior rectus? Because we might find this might have, my muscle may have a stretch scar, may have a slippage, something. Let's find it. So we did a very quick exploration. It was easy to find. We found the inferior rectus quite posterior. Even the recession was only 5. We found the inferior rectus about 12 from the limbus, and we advanced about 4.5 millimeters to what supposedly should have been at the beginning. We had no complications. It was quite a straightforward case. And 4 weeks after surgery, he was doing very well. He was happy. He was back to his life. Then he came back 6 months later, but now we went back to the right hyper of 25. But now we have a significant exaclotorsion now. And the Dole Maddox rod is showing us that he feels there is significant amount of torsion. And we found that this was unexpected 6 months later, but at this point in time, I asked specifically about his health, and he was almost entering a thyroid storm. He was in a really bad situation at this point. So we stopped everything in our service. He was sent to endocrinology. He was in endocrinology for about a year. They did full thyroidectomy. He was in medication until he came back to us. So he disappeared for about a year. When he came back to our service now, these are the CT scans after he came back after the thyroidectomy. And now we could look into some of these muscles starting to be enlarged. Specifically, the superior obliques is starting to show that a little bit enlarged. The inferior rectus and the opposite side, Cami, as you were saying, the other side, the left eye, the inferior rectus is also tight. So we have now a conversation with him about what to do next. And we decided for surgery again. And now he was convinced he needed surgery in both eyes. But now our approach was, okay, now we need to do a superior rectus recession, because now we have unmasked a complete thyroid that is affecting not only the inferior rectus in the right eye or in the superior rectus in the left, but actually the superior rectus in the right and the inferior rectus in the left. Now all these muscles are now affected. And we propose to do a small superior rectus recession on 5 millimeters in the right eye with the left inferior rectus recession of 4.5. And the forduction test also show us how tight these muscles were. But historically, we try to address the exaclotorsion. If we can, we're using the inferior rectus, most likely because of the tightness with the recession, the torsion sometimes may disappear. We consider that 15 degrees of exaclotorsion was maybe a little bit too much. So we use Dr. Beldes and Dr. Pinelli's described several years back, the anterior tuck, right superior oblique. This is a technique that I have been using in my practice with excellent results. We decided to, now that we were doing a superior rectus recession, do right there a tuck of the anterior tuck of the right superior oblique. And the results were very, very good, actually. This is about a year and a half later, following this surgery. The results have been very stable. This is what is measuring right now. He is happy because the torsion is only 4. And he says that he's able to control now the torsion. And down gaze, he only has two prism diopters. While he's a little bit higher when he looks up, he is able to compensate quite well with very small. My take points for us in this is as it was in this case, once we do one muscle, we unmask other ones. A thyroid disease affects every single muscle, and we always need to be ready to know what's going to be our next step. Thyroid disease is really unpredictable, but we need to be sure and be ready what we are going to do for our patients.
Thank you so much.
And that's all. Thank you so much.
We're going to move on to Dr. Gunton with her case next. And you're still muted.
Thank you so much. I'm just going to do a start 1 second. Okay, so my case is involving double vision with a tube shunt. I also have no financial disclosures in regard to this presentation. This is a 66-year-old female with a history of open-angle glaucoma, worse in the left eye, who reported double vision following the placement of a Bearvelt 350 tube shunt. It was placed in the supratemporal quadrant of the left eye 3 months ago. And the double, she reports, is diagonal and a little bit torsional. Her past ocular history is common for glaucoma patients. She had a GAT in the left eye, and then 2 years later, had a trabeculectomy. This was complicated by needing a revision and then a scleral patch graft also in the supratemporal quadrant. She developed some macular edema following, and then now she has had the Bearvelt valve placed. Regarding her double vision, she has no history of strabismus in childhood. The double did begin immediately following the tube shunt placement, and she reports that it's constant and mostly diagonal. No improvement in the double vision in regards to the distance of the images or the frequency over the last 3 months. Her vision was good, slightly reduced in the left eye because of the macular edema. She's mildly myopic. She has some ptosis that's pre-existing in her left eyelid, and the slit lamp exam is consistent with having had a tube shunt. The appearance of the bleb is relatively small. It's a small bleb, it's clear, it's not inflamed, and her intraocular pressure is now 12 in the left eye, which is at target. Sorry, there we go. And her motility exam. So she has a left hypertropia, the same as the side of the tube shunt, that is worse in down gaze. So it increases to 16. It's relatively similar in right and left gaze and slightly less in up gaze. She has an exotropia of 20 that is comitant. I did do Maddox rod testing because she reported some torsion, but I did not see evidence of significant torsion in either eye. And she was able to fuse without correction of the torsional component. Actually, I'm just gonna stop right there and ask what would be the considerations in regards to treatment of the strabismus.
Okay. Hi, I'm Hilda. We're discussing Kenny's case. So I think when we see a patient with barbell implants, first thing we try to think is what is the mechanism causing the strabismus? And we like to think if his eye moving towards the implant or away from the implant. If it moves away from the implant, it tends to be like a bulk effect from the implant itself and the filtering bleb. If it moves towards the implant, I think the mechanism tends to be just stretching of the muscle, lateral rectus and superior rectus muscle, acting like resection of the muscle and pulling the eye in the direction of the implant. And I think that's the most common. We kind of look at the patterns, and the most common deviation was a hypertropia and exotropia in patients with supratemporal implants. In terms of what we can tell the patient, what to expect from the surgery, we look at the surgical outcomes back in 2017, and we found that unfortunately the motor success is not as good as in patients that don't have the implants. We found motor success was close to 50%, and about 75% of the patients had improvement of the alignment by at least 50%. So they were satisfied. We were able to reduce deviations. probably fit them with prisms and improve the cosmetic appearance. In a patient like this, in terms of surgical plan, when I look at them, I first thought, well, what is the largest deviation? I cannot operate in all the muscles. So I said, well, the exotropia seems to be larger than the hypertropia. So I try to address then the horizontal component and move the muscles down, trying to pull the eye down and get some of the vertical correction. I can anticipate that I will not be able to fully correct the hypertropia by moving the muscles down, but I may be able to alleviate the hyper, make it smaller, and allow the patient to fuse with the prism. If this is not enough, I can always consider second surgery and do a recession of the inferior rectus in that contralateral eye. Always warn the patients, there's always a risk of perforation of the bleb. It doesn't happen as frequently as we think. I think I've done at this point like 30 patients with glaucoma drainage devices. I've only had 2 patients that developed hypotonia. At the time of the surgery, there was a small filtration. We reformed the chamber, and we were able to proceed with the surgery and complete the surgery as we had planned it. So I'll be interested to see what you decided to do in this patient.
Exactly. Right. I was thinking that there might be some scarring or fibrosis around the superior rectus. And I knew I had a functional tube shunt in a patient who has pretty significant glaucoma. I wanted to try to preserve that. And there was a lot of scarring. As I said, she'd had previous glaucoma surgery. So I did ask our glaucoma colleagues to be present. As you said, I've done a lot of surgeries on patients with tube shunts, and I have not had perforation until this case. So on the day of surgery, I decided to do 4 suctions, and they were mildly positive to down gaze, indicating that yes, the superior rectus was tight. So I approached the superior rectus supranasally and was able to hook it with no problem, thinking that I might be able to release some of the scarring around the muscle. It was going great until there was a little gush of fluid and the anterior chamber began to flatten. As you suggested, I injected VSS into the anterior chamber, and because my glaucoma colleagues were not far away, I said, help, and they went ahead and injected some viscoelastic into the anterior chamber. So the anterior chamber was holding, but I was a little bit more chicken than you were in regards to proceeding with the surgery. I was afraid if I manipulated more around the superior rectus to free the scar that I might get the chamber to deflate and maybe lose the tube shunt. So what I decided to do was to move to the other side, recess the lateral rectus. And because the superior rectus, I had partially cleaned it, I decided to do a myectomy, but I don't think I did enough, mostly because I didn't really want to manipulate the eye very much. And the postoperative course, as you would expect, showed undercorrection of the left hypertropia with a little bit of torsion at the very beginning that resolved quickly. The exotropia was well taken care of, so that part was good. And unfortunately, her ptosis also worsened. So I watched her for some time. I tried to give her prisms, and I ended up with the same left hyper that she had pretty much had before I did my surgery. So left of 10 and worsened down gaze. But she can't wear prism because she hates that left hypertropia in down gaze. The exophoria was not bothering her at all. And so at this point, after waiting and hemming and hawing, I decided that I needed to do surgery again. I did not want to go near the superior rectus. I still do think that is the cause of my problems, but I don't want to go up there again. And the bleb is still working, and I didn't want to take a chance. So I ended up in this case doing a left inferior rectus plication, and she luckily did very well. So she had a left hyper of 2 at the end, exophoria, she had her ptosis repaired, and the bleb is still working. So I didn't prepare a takeaway, but my takeaways, I think, are that sometimes you just have to move away from where the scar tissue is because you simply can't free it up and maintain that functioning bleb. I would maybe have loved just to recess the superior rectus while I'd been there. And the thing that I learned about this is, as you reported you do, and also Dr. Rosenbaum reported a case, that you go ahead with the strabismus surgery, and most likely the chamber is going to stay formed, especially with viscoelastic in the anterior chamber, and that the bleb is often saved. So thank you.
Awesome. Thank you so much for that case. That was great. We're going to move on to Dr. Dagi next.
Okay. Let me find the share. Sure. Okay. So I have a fun case called Bearing in Mind the Biker. So prior history, the patient's a 59-year-old female massage therapist and a competitive mountain biker. It's a very important part of her life. Her previous physician retired and scant records were available except for operative notes. So I did find something about her prior history I'm about to share with you. But basically, before all of her problems started, she had a long-standing history of a presumed congenital right cerebral palsy with a lifelong head tilt to the left. There was no intervention for it. Her parents didn't want to intervene. She had mild and isometropic amblyopia, but good fusion. At age 49, her life changed. She was diagnosed with thyroid eye disease. It seems to be a theme today. In 2006, she had a thyroidectomy, thyroid replacement, and synthroid. In 2006, also, she had bilateral fat decompressions for proptosis, which was worse on the right, and more was done on the right. This was followed with blepharoplasties bilaterally with use of retroauricular cartilage to support the lower eyelids and get rid of that sort of sagging lower eyelid, and upper eyelid retractor release. Strabismus comes next. By 2007, she had developed an extreme chin-up posture to fuse. She could no longer bike or work. It was hard to maintain fusion in any location, and she often went around monocularly occluded. This was before she had come into our practice, and this was just from prior operative notes. In 2007, she had a right inferior rectus recession of 8 millimeters, which was a big undercorrection, and the surgeon augmented it to a 12 millimeter inferior rectus recession from the anatomical insertion. It was still undercorrected, and several months later, he went to the contralateral eye and did a superior rectus recession. So quite a bit of surgery for this right hypotropia in this patient who also had a cerebral palsy. After 2008, she was left with single vision only in extreme upgaze. It was now kind of in reverse, a large chin down posture, which was good for her biking, but impossible as a massage therapist. She was frustrated again, monocularly occluded almost all the time, and she presented to us in 2015. Which is where the story starts here. So here she comes to Boston. Her refraction shows some anisometropia and a little amblyopia in the right eye, but it's really not pertinent to this case. You can see she has significant infraduction deficit in the right eye, and she has a right hyper, worse gaze left, worse head tilt right, not too surprising with her prior history of cerebral palsy, and a huge right hyper in down gaze. She's got significant excyclotorsion. Near, she's a right hyper of 20 as well. Crude fusion and upgaze with her eyes gaze right and head tilt left. Significant proptosis to the right eye, a lot of fundus excyclotorsion. And she's also bothered because her left lower lid covers her dominant left eye in reading position. Now, I actually thought the left lower lid was doing a good job here because she has such a big hyper and down gaze, but she was not pleased by that because it was her dominant eye. And here's what she looked like. Not really so terrible. She had had a lot of eyelid surgery and a lot of surgery for her proptosis, but you can see she has this right hyper, worse gaze left. MRI showed inactive tendon sparing enlargement of the inferior rectus muscles bilaterally were involved, though less dramatically so other muscles, and no obvious asymmetry of the superior oblique or the inferior oblique in either eye, and proptosis of the right eye. So the first question is, what makes this patient different from your standard thyroid eye disease patient with an overcorrection after surgery for her unilateral hypotropia? That's the first question. The second question is, why is the dominant eye occluded in reading position? What's going on here? What would you do next as her surgeon? And how do her needs differ from that of the typical thyroid eye disease patient with a large hypotropia? So Federico, I'm turning this over to you. Not too complicated, but it's an interesting case.
Well, if you think it's not too complicated, that's complicated enough.
It's complicated enough. She's had a lot of surgery.
All right. So, I mean, I would say that this patient really mixed two complicated conditions. One is a presumed congenital superior oblique palsy with a right hypertropia. We don't know really, we don't have any data. How was it before the patient
That's
developed
correct.
this thyroid
We
eye
have
disease?
no data.
So we don't have really any information of what the patient was able to fuse and in which position the patient was able to really be comfortable other than the head being tilt. But we're not sure if it's what better with the patient looking in up gaze or down gaze. However, I would say that if a patient has a congenital superior oblique palsy, frequently we see some patterns, such as, for example, a lax superior oblique tendon that could be compromised and can cause a deviation that is larger in down gaze. The patient was not, I mean, she was a biker, so I assume that at one point she was able to fuse in down gaze and in up gaze. I don't know what kind of biking she does, which is quite different between mountain biking looking in down gaze, believe it or not, and a road biker who has to look in up gaze. So those are simple things. So I think that the standard thyroid eye disease patient probably will have tight muscles, but here we're in the presence of a superior oblique palsy. When I look at your picture and I say, well, why is the dominant eye occluded? I mean, is the patient having a hypoglobus or a big hypotropia, and she is forced to fuse with the paretic left, right superior oblique muscle that had the previous paralytic strabismus, but her visual acuity is worse in that eye. So I don't know if it was always worse or this patient always had a situation where she actually had a left eye, the right eye was dominant before, and she could be fixing with her paretic eye, in this case, the right eye. But I mean, it seems to me that she's just covered in down gaze by the large hypotropia that she's developing with her left eye, I believe. Actually, this picture is very interesting. The information on this slide, and I thank you for putting it, because you said that there's no obvious asymmetry between the superior oblique tendons. I still question the information, for example, in patients that could have a lax superior oblique tendon, if they could or they cannot have an asymmetry on the superior oblique tendons on an MRI scan, other than the muscles being weak or when we explore them being lax. But that's the tendon, not necessarily the muscle. And the muscle could be normal on an MRI scan, plus that this patient has a thyroid eye disease. So with a thyroid eye disease, a muscle that could be smaller now could be infiltrated, and then it could become normal in an MRI, even if it was an atrophic extraocular muscle because it was hypoinnervated. And there was another question over there. And you can go to the next slide. Okay. What I will do next? Well,
Questions.
okay, so that's a question for you because you're the one who did it. But I think this is interesting. The patient started with a right hypertropia. Then the patient is really great in down gaze because it has a big chin up position with down gaze. And at that point, they decided to recess the inferior rectus muscle really far back. That big recession can explain a large right hypertropia. You want to go right there. And the recession of the left superior rectus muscle in a patient with thyroid eye disease could result in a contralateral inferior rectus muscle that could be involved and then pulls the left eye down. That can explain also why the patient best seeing eye is just too far down. You don't describe any limitation to vertical ocular rotations, like a limited elevation in the left eye. I'm not sure if that's correct or not, but that can help because, I mean, if the patient really doesn't have any restrictions, then you can make a decision if you want to go and advance the left superior rectus muscle, or you want indeed, because of the large deviation in down gaze, better to just go for the left inferior rectus muscle and manage this patient like a typical right superior oblique palsy with an exploration of the right superior oblique, or if you prefer, then just do the right inferior oblique that maybe is also tight, and the patient could have what I have heard Dr. Guyton, I don't know if he described it, what is called a reverse Brown syndrome, which is a condition where you have a restriction in downward rotation in the field of action of the superior oblique, but it's actually caused by a restrictive inferior oblique, and that will markedly improve when you recess the inferior oblique, and then you can just do the left inferior rectus muscle.
Those are all great thoughts. I think I presented this case for a couple of reasons, but let's go back here. What makes this patient different from a standard thyroid eye disease patient with an overcorrection after surgery for her, quote, unilateral hypotropia? Well, the reason I presented this case was exactly that. She had a history of superior oblique palsy, which was true and will turn out to be true. That would have given her right hyper, yet she had this massive right hypo, and the surgery itself, I think, just unleashed what she had before. It was a huge amount of surgery. You know, ultimately her inferior rectus on the right was recessed 12 millimeters and the contralateral superior rectus. So I think it was a huge amount of surgery given this history. Why is the dominant eye occluded in reading position? The prior blepharoplasty with the use of this retroauricular cartilage made the left, I keep going back that way. I don't know why it's going in reverse, but I've done this now twice. If you go back here, you can, I apologize for these technical details, but this is being blocked on my screen. You can perhaps appreciate I'm like afraid to go back. That her lower lid on the left, you can't see it so well here, is lower. And every time she looked down, she could not see with her dominant eye. Her right eye had some anisometropic amblyopia, and that was the issue there. I do apologize here why this is happening. I cannot tell you. Let's go back to where we are in this case. And get back to our slideshow. Okay. So it took me 2 interventions to get it right. The first was acknowledging the importance of the superior oblique palsy. So I did a superior oblique tuck on that side, 7 millimeters. It was mildly lax, and a left eye inferior rectus recession at the same time. So you can see the pre-op motility on the left lower area of the slide, right hyper of about 20, worsening to 35. And she was definitely had an undercorrection, a mild undercorrection. But it did help the situation significantly. So she was very happy for 2 years, and this is not such an uncommon situation with a thyroid eye disease patient. They're happy for a while, and she was back to work and with competitive racing, fusing both chin up and chin down, though I was quite surprised by that given her motility. So after a period of time, that right hyper returned in spite of the right superior oblique tuck and the contralateral inferior rectus recession. It would build over time, and her cyclotorsion grew as well. So I went back, and her problem was, you can see in reading at distance, she was pretty straight most of the time. In reading, she was kind of cocking her head to the side. So procedure 2 was to recess the inferior oblique on the right, like the simplest procedure we do for superior oblique palsy. Not sure why I didn't do it before, doing something like a tuck, but I went ahead with an inferior oblique recession, and the left eye, I re-recessed the inferior rectus from 7 to 10 millimeters. And she really was left in quite a good position. She had rare diplopia in primary. She thought it was perfect for racing because she was chin down for racing her bike, and a mild chin down to read, and she's been stable now for 5 to 8 years. So I think that the reason I presented this case was simply because of the complexity of having someone with a superior oblique palsy as well as thyroid eye disease, and keeping in mind someone's prior pathology, which could impact surgical procedures done to take care of the new pathology. That's really why I presented this. And she had had quite so much surgery, both on the lids and eyes, and it took some time to get her right, but we were able to do so. So thanks for your participation in that, Federico. Thank you. And here she is. She's been quite straight for quite some time and doing well.
Thanks for another great case. I think you guys see the most complicated things. These are amazing cases. So we're going to go on to our last case with Dr. Federico Velez.
All right. Let me just go here. Just to confirm, can you see the slides? All right. So finally, an easy case. All right. So thank you for all the previous presenters because I mean, your cases really are unbelievable. And thank you to Dr. Capo and Jason Paragallo for a wonderful webinar and for the invitation to be here today. And this is the title, Some Help is Needed, What and When. And I don't have any really financial interest other than I am an strabismus surgeon, like Dr. Kraft says. And this is basically a real story. This is an 83-year-old patient who actually was seen in the retina clinic with a history of blurred, cloudy vision in the left eye for 1 month, flutters and occasional flashes of lights. And then this is what the patient had. And I actually just cut down 2 slides because I know it's late. But basically, this patient is diagnosed with a choroidal melanoma. So this is 18 months ago. A month later, the patient undergo a plaque brachytherapy in the left eye. I am actually performing surgeries on a different room on the same day this patient is having his plaque placed. And a nurse came and said, doctor, they're wondering if you can take a quick look of a muscle in a room next door. At that point, the plaque has not been placed yet. When I walk in, the superior rectus muscle is gone. So they basically had a full thickness, very posterior, left superior rectus muscle dehiscence, basically a pull into superior rectus muscle. And so I want to present this case to see what Manasa will do, because I think you're going to be the one discussing the case. And I want to stop here. I'm not going to tell you anything more about the case. So what is your approach to manage a posterior pull into superior rectus muscle during a plaque implantation? And the plaque actually is going to be placed near the area of the superior rectus muscle, very posterior. Then what would you do there? I mean, you have a pull into. Second, how long will you wait in case you need to go back to do more surgery? And I'm going to present a little bit later. I know the information is limited, but I want to know how you think, because that's how I have to think that day.
Yeah.
Then knowing the history of this gentleman being 84 years old, what are your concerns and considerations? And the last, if the patient were to have a severe persistent elevation limitation, what would you do?
Well, thank you for allowing me to help guide you in your decision-making on this very straightforward case, as you mentioned, and very common. So, you know, to start, first of all, pulled in two is, although we've all probably seen it, hopefully not more than a couple of times in our careers, it's something that most of us will probably encounter, but it is quite rare. And strabismus following plaque implantation therapy is also, it's not quite common, at least to be persistent strabismus, while transient strabismus after this type of surgery is can be seen for sure. Seeing it more long-term is not so common. So I think that you have 2 rare things happening at the same time, which adds, of course, to the complexity of this case. So if it was a very posterior disinsertion of the muscle, I would first try to see if you can recover it. I think that, you know, in general, for pulled in 2 cases, the first modality is to attempt a possible recovery. If, you know, especially with the superior rectus, because there are some attachments to the levator, it might be a little bit more easy, not really, but it might be a little bit more easy than let's say the medial rectus muscle, where it's much more common to see a pulled in 2, but much more difficult to manage. So if you can find the posterior stump and to either reattach it to the globe or to the anterior portion of the muscle, I think would be sort of the first thing to try to recover the muscle. If you cannot, then I think that, you know, allowing the implantation of the plaque to continue, because that essentially is what is sight-saving and potentially life-saving for this patient, obviously will have to continue. And then most of the time, these plaques are then removed within a week. So you have the opportunity to then reapproach the eye when it's potentially less hot or less bloody, and but still with not so far of an interval to allow for a secondary contractor of the antagonist muscle, and also like maintaining the eye it might actually help you just to give that time between the two surgeries. If you were to recover the muscle, and you do need to do further surgery, I think what's considering in this case, and also in any PLDN2 case, I would wait if you needed to do further surgery, if you can't recover the muscle, I should say, or you have a persistent deviation, I would certainly wait at least 6 months' time prior to considering any other surgery for multiple reasons. First of all, with PLDN2, when the muscle reattaches, you might actually get more force to the muscle than you would expect, or that's originally seen at the time of the surgery. And then secondly, in this particular case with the plaque radiotherapy, that in itself could also alter the behavior of the muscle where the plaque is placed. So in this case, the superior rectus. So it's a little unpredictable what will actually end up happening with the motility as well as the alignment, in this case, more long-term. So certainly waiting that time. And then knowing the history with special considerations, in addition to kind of what we talked about right now with the plaque radiotherapy. In this particular patient, given his age, we've already lost one vertical or one rectus muscle. So we have to always consider the possibility of anterior segment ischemia. And this patient has multiple risk factors for that. But also maybe there's a little bit of a saving grace. If there is some vision loss, given where that tumor is placed with the radiotherapy, you might actually not have as much of a pressing indication to do surgery from a diplopia perspective, which might buy you a little bit more time as well. And then for managing a persistent severe elevation deficit, some sort of heroic transposition surgery might be necessary, and potentially looking to the other eye and doing either if there's some sort of a muscle surgery, or potentially even a posterior fixation if there's orthotropia and just an elevation deficit.
Perfect. All right. Well, thank you. I think you basically said exactly what I thought about it. All this in 2 minutes, right? I have to make the decision what to do in the operating room with that muscle. So the muscle, whatever looked like a muscle that I wasn't sure it was a muscle, looked very posterior. It was really deep into the orbit. So at that point, really, the surgeon is the retina surgeon. They said, look, I think that could be the posterior part of the muscle, but it was really posterior and it was really deep. So let's try to get a non-absorbable suture into that piece, because anyway, I mean, they're going to place the plaque in that area. So they're going to need to hem back a muscle. I know that's what they were going to do originally, and put the plaque. A week later, remove the plaque and advance the extraocular muscle. But then I said, well, I have seen enough patients with a plaque that the muscles become very underacting from radiation, probably radiation damage, because these muscles are large, but they're underacting. And that's very typical. I see all these patients having like a underaction of muscles, but when you go and look at them, they're large. So it's kind of the opposite of a thyroid eye disease. And there's always some scar tissue formation. And I wasn't quite sure even about the superior oblique, what was going to happen, because everything was going to be up there. So my decision was just put that and then just send the patient to me. We will find out what to do later. Okay, so that's basically what I said here. We put this suture and the plaque is removed, and then the patient is referred to me 2 months later. And here is the video of the patient. So the patient has very severe diplopia in the primary position. He has a severe limitation to elevation in all gazes with the left eye. He has a large hypotropia, and I mean, his other motility is completely normal. I hope the elevation is going to show up here, that he has limitation. He can move, because I know, I mean, the muscle was back there somewhere, but it's really posterior. And I have the same considerations you mentioned. I mean, it's anterior segment ischemia. I'm going to wait several weeks, perhaps months, before I go and explore. So then I finally obtained an MRI, and the MRI to me showed the bulk of the muscle really far back here. But I said, well, this looks very thin, and there's maybe an attachment. There's maybe something here. I think it's worth, and as you say, yeah, it's very close to the elevator, but I know the bulk is really far posterior. So we still need to wait. And then the patient got sick. This is 6 months later, and I'm just going to present this video where you can see that, I mean, he barely passes the midline, but he has like 25 prism diopters of a left hypotropia, very disturbing. He can actually almost fuse in the extreme down gaze, okay? So, and this is actually, I'm sorry, 14 prism diopters. We have the patient ready for surgery and the patient got sick. So we have postponed the surgery a few more months. And now it's time to go to the operating room and do surgery. So I have the same concerns you mentioned. I added just the myopathy because I have seen it many times. And very clear, this patient said no at all to surgery on my left eye. And surprisingly, he actually had very good vision in this left eye. So this is my preoperative before the surgery that I performed. And what we did, I mean, again, this is the limited elevation. So we did an orbitotomy. And with the orbitotomy, we were able to actually recover his left superior rectus muscle because we have put this non-absorbable suture. We were able to identify there was some scar back there, but we found the muscle, which the suture helped tremendously because it was really not easy to see muscle fibers, but yes, the suture was attached to the stump, very posterior. And at that point, we recovered the muscle and then where to put it. So I said, well, I have to make a decision how much hypertrophy I'm gonna induce. And like any other patient with a nerve palsy or severe limitation, if I have a patient that has like this one, an overcorrection postoperatively, I'm very happy because at least I know that I addressed the problem. Then I can go back and recess the muscle. The same I say with third nerve palsies. If I have an esotropia, great, we celebrate. So my technique for advanced muscles that I don't know where to put is exactly what I write down here. I usually rotate the eye in the opposite gaze position to a position of about -1, what I consider -1 in my head. And basically, I advance the muscle as far anteriorly as I can. And I mark that position. Well, look where it was, 8 millimeters posterior to the limbus. So that was really surprisingly because this was a very posterior superior rectus muscle, full dehiscence. But I was able to advance this muscle to 8 millimeters posterior to the limbus. And this is the patient in the postoperative alignment. This postoperative alignment is 1 week after surgery. This is the postoperative alignment. Sorry, there should be another one. Yeah, 3 months. The patient has 6 out of 9 circles. His visual acuity is 20/25 in both eyes. And the patient is orthotropic with some esotropia in left gaze. So my take message, besides everything that you said, that I totally agree with what you said, is I don't think we have to honestly be too concerned on recovering muscles too soon. I think if you can recover a muscle and you feel happy, I mean, comfortable putting a stitch and advancing the muscle right away, go for it. But muscles can be recovered later with the proper technique and the proper help. I have an orbital surgeon that came in with me, and he feels very comfortable going to the orbital apex, and they basically handle the muscle to me and do whatever you want. But I think that the teaching point I want to bring on this case is that I have seen a lot of pulling two muscles for different reasons, and I'm becoming a little bit more conservative of when I want to go back and fix them. Thank you very much for your time, and thank you for your discussion. Great job, Vanessa.
Thank you so much, Federico. So we have a couple of questions from our audience. For Federico, would you consider in the acute situation, Botoxing the inferior rectus muscle?
I didn't think about it right there, but when Vanessa was discussing, I said like maybe I shouldn't think about putting Botox on the inferior rectus. So I think it would be a great idea. I mean, at the very end, I said I didn't need it here, but I agree with that question, and I think it would be probably the best option.
And then for Cami, there's a couple questions about your case. Which conjunctival incision was used for approaching the superior rectus muscle?
I ended up putting an incision that was essentially a paralimbal incision in the supranasal quadrant, so I could get exposure over there. That's what I did.
And then was there any follow-up after the first month at this point? And was there any undercorrection? The concern is about scarring or restriction from the plate that's still present.
Yeah, I actually have 1 year follow-up on her, and she did have a little bit of recurrence of her hypertrophy. So it was 2 at post-op month 1. And at 1 year, I put her in about 3 prism diopters of vertical prism, and she's quite happy. Mostly she's happy because she can read.
And then this question is really for anyone with any thyroid cases, but I know we had 3 of them. So how long do you recommend waiting to do strabismus surgery in a thyroid eye disease patient? This is for anybody who had a thyroid patient.
Jason, I can answer that one, that question. Definitely, we want to be sure that metabolically the patient is really well controlled. We have seen how these changes, how we have dramatic changes in the patients which are unstable, or the thyroid keeps adjusting. I normally ask my patients to be at least 6 months to a year after they have finished all the treatment before we intervene. And when we have more angle stability, and that has been perhaps when we get the best results.
I also know that our oculoplastics doctors are checking TSI and looking to make sure that the TSI is well controlled as well, to look for exactly that you're quiescent.
Mm-hmm.
How does the use of Tepezza influence your decision to do surgery, or what kind of surgery you do, or how much?
I think that has been a game changer in oculoplastics, and we see how the big changes in the orbit. Definitely, when I have a patient that is being active in the treatment, although here in Canada it's not as much in the as it is in the United States, we try to hold until the treatment has finished, and we are absolutely sure it's not going to change, because definitely there is regression and the numbers reduce dramatically.
Can I make a comment on that? I've
Yeah,
had
go ahead.
numerous patients. I honestly, the only thing that I see changing, at least on the patients that come to me, is that the force reduction test is more of a normal situation. But the reality is that couple of papers that were published, and I have the fortune to be involved, didn't demonstrate really much of a significant improvement on the real prism diopter movement measurements on the patients treated with Tepezza. So yes, you have to finish with the treatment before you treat them, but still strabismus surgery will be needed in many of those patients. That's my personal experience. But the muscles behave more like tight, elastic muscles. That's my personal impression.
I agree. And you're more likely to actually potentially overcorrect, which was harder to do pre-Tepezza with thyroid patients. But I found in a couple of cases, actually, in my postoperative adjustment, that they behave more like a quote unquote normal case, where my standard measurements actually would work well, versus with thyroid cases when I often have to aim for higher.
I'm going to open it up to the panel for any other comments before we end the session. Anything else anybody wants to talk about? All right. Well, I want to thank everyone for participating, all of our attendees and all of our panelists. Thank you so much for preparing for this webinar. I think it went excellently, and I'm really happy about all these complicated cases. We see some of the most complex things in our practices, and I think that this was really humbling. So thank you so much.
Thank you for having